Thank you, everybody. Sorry, I got lost in a little bit of Jill Scott behind the scenes there. Thank you for that song to start us out. I'm just opening up everything here. Wow. Thank you to everyone who has joined us for the last months of our speaker series with the Equity, Diversity, and Inclusive Office here at Sick Kids. We are so proud to be part of these conversations. To those who don't know me, my name is T. Garnett. I am the inaugural executive lead and strategic advisor of Equity, Diversity, and Inclusivity here at Sick Kids. I have been with the organization almost 1 year. My birthday with anniversary will be March 29th next month. And so it has been a busy 11 months at Sick Kids as we continue to join in the conversations and movement. None of this would be possible, the speaker series. So I want to pause and really put the praise and accolades where they are due to LICSW, our students here within the office. LICSW was the inaugural executive student of Equity, Diversity, and Inclusion here at Sick Kids. She comes from a wealth of information, including being a qualified legal practitioner, graduated from the University of Kent at United Kingdom, and was called to the Nigerian bar in 2017. LICSW is currently enrolled in the MBA program at McMaster University, and in her previous role as a corporate attorney, represented numerous clients in regards to issues of equity, diversity, and inclusion. And it is with great praise and humbleness, I thank LICSW for her work and her support in this initiative and all she has done since coming into Sick Kids a brief 6 weeks ago. This series is part of a month-long speaker series that really started with hearing from our community, our Black community, in regards to Black health and wellness, which is the global theme for this year's Black Health, Black History Month. And Black history and liberation is what we are celebrating here at Sick Kids. And we started with the community of listening, sharing with Paul Bailey and the president of Ontario Black Nurses and Dr. Cassia Johnson and Dr. Sharon Smile to understand the pediatric implications of Black health and wellness. Last week, Dr. Lana James led us through the implications of machine learning and AI on Black populations' health in Canada. And this week, Alicia is bringing us home in regards to what our world and conversations will consist of after these conversations of using evidence-based data, both in patients and workforce, to guide and lead the changes. And so I am honored to be working alongside Dr. Natalie Desiree. I hope I said that right, Natalie. One of my key issues here at Sick Kids is really shining the light on the wonderful and amazing staff that we have, including Dr. Desiree. Dr. Desiree received her PhD in clinical neuropsychology at the University of Montreal and completed a postdoctoral fellowship in pediatric clinical neuropsychology at Alberta Children's Hospital, where she was also worked as a staff neuropsychologist. Dr. Desiree is currently a staff clinical neuropsychologist at Sick Kids in the Division of Neurology and Plastic and Reconstructive Surgery. In her role, she provides culturally sensitive and inclusive assessments, intervention, and consultation services for children and families following neonatal brain injury with congenital or craniofacial or neurological conditions. Her research interests focus on examining the neurocognitive and psychosocial outcomes in children and youth with acquired brain injuries and neurological conditions. Dr. Desiree's interests also include addressing and disrupting equity, diversity, and inclusion issues within the field of psychology. She's involved in several initiatives, EDI initiatives across Sick Kids, and is an active member on the Black Experiences in Healthcare Working Group, the Sick Kids EDI Steering Committee, and the Mental Health Strategy Advisory Committee. Without further ado, I'd like to invite Dr. Desiree to the stage, who will lead us in our conversations in our community speak for today's event. Dr. Desiree.
Thank you so much, T, for this introduction. Welcome, everyone. And as I stand here today on the shoulders of my ancestors and those who came before me, it is really important to understand the long-standing history that has brought us to reside on this land. and to seek to understand our place within that history. And so I would like to begin by acknowledging the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and the Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. And SickKids is committed to working toward new relationships that include First Nations, Inuit and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. And now it is my pleasure and my honor, my privilege to introduce shortly Alicia Adiele. But before we do so, I do want to acknowledge that as we engage in critical dialogue through conscious questioning and active listening, that this is a safe space. And here across the world, and in SickKids in particular, we welcome all peoples of the world and respect as we build our diversity and as we build solidarity in healthcare. We do want to highlight that respect is a priority as well. So without further ado, I would like to introduce our next speaker, Alicia Adiele. Alicia Adiele is a licensed independent clinical social worker and obtained her master's in social work from the University of Washington. She is currently the Senior Director of Health Equity, Diversity, and Inclusion at Seattle Children's Hospital and leads initiatives to enhance equity-focused research, quality improvement, bioethics, and workforce engagement in EDI and anti-racism. Alicia's experience as a clinical social worker in community mental health, Washington State Department of Children, Youth, and Families, and hospital social work has contributed to her dedication to achieving health equity in health institutions. Alicia is committed to identifying existing health disparities in health outcomes at Seattle Children's by utilizing data analysis and transparency and developing interventions to address potential inequities in care. Now, please join me today to welcome Alicia Adiele.
Hey, thank you so much. I will say I'm feeling very energized, starting off the day with a little Jill Scott. Can't ever go wrong there. So I'm very honored to be talking with all of you today. I really want us to see this as a conversation. I'm going to share some good and some bad and some positive details of the journey of Seattle Children's that we've been on as it relates to equity, diversity, inclusion, and anti-racism. So again, my name is Alicia Adiele. I use she, her pronouns, and I'm the Senior Director of Health Equity, Diversity, and Inclusion at Seattle Children's. I support teams like the Center for Diversity and Health Equity, which is really focused on health equity research, pipeline and pathway into health sciences, patient outcomes, quality, and how we embed equity into our quality and safety systems, as well as trying to transform bioethics into an initiative that recognizes racism as an ethical issue, which across globally, that's not really something bioethics has typically done in healthcare in the past. I also lead our workforce inclusion, diversity, equity, and access groups, which is really focused on how we create a workforce that is diverse, inclusive, and really stands for anti-racism every step of the day. So I'm going to go over from starting in 2020 to current state, this journey of anti-racism at Seattle Children's. It is definitely one of some challenges and celebrations, which we will go into more detail about. And I want to start by saying that our CEO, Dr. Jeff Sparing, publicly acknowledged that Seattle Children's is not an anti-racist organization. And we recognize that meaningful culture change, which is what we're trying to do, does not happen overnight. It takes time, but our commitment is relentless and we are acting with urgency. So we have an executive leader and a board of trustees that supports us publicly going on record saying, we're not there now. We are committed to it. We're going to invest in it. And here's a snapshot of how we plan to do it across the multiple domains and systems at our institution. I think it's important to have leadership and CEOs and executive leaders model this and stand true to this. And that is something that we have as a foundation at Seattle Children's. So our strategic vision really started in 2020. Now, as most of us have been impacted by COVID-19, we very quickly saw the inequities and disparities with historically disenfranchised communities as it relates to the pandemic. And then, as most of you probably recall, we all witnessed the gruesome of George Floyd. And for the first time, and what felt like, in my lifetime, society was listening, that racism was real. And so I'm not one to read from my slide. I think this is an important statement that went out, that Seattle Children's is dedicated to becoming an anti-racist organization. We must pursue and prioritize actions to ensure equity by becoming the most diverse and inclusive organizational culture that our community, our patients, and their families deserve. We committed to this in 2020 because we knew that we had to accelerate this. The Center for Diversity and Health Equity had been a system and a center within the organization since 2008. The mission of this center had never changed. The vision of the center had never shifted. And in 2020, we finally had a listening ear. We had executive leaders who were interested in the work that we were doing and wanted to enhance our programs. We recognized very quickly by partnering with our Center for Quality and Safety that we had disparities in our health outcomes. And so on a typical quality core measure dashboard, you might see some green metrics. Our center comes in and we very boldly say, I want to see those metrics by race, ethnicity, language, payer, zip code. And all of a sudden that green metric turns red if you're Black or African American, if you use a language other than English. And so it's really, really important that, Seattle Children's took a step that we needed to recognize these inequities and think about it, because when you know something, you have to do better. We also know that the tragic acts of violence and racism across the country really did propel most folks, not just healthcare institutions, but even up to our government and policies and housing and education and our justice system. At this point, we could no longer ignore these realities, and we needed to make a commitment to do something better. It was no longer acceptable to just be not racist. Seattle Children's, we also recognized that we had to pave the way and we had to be accountable to fostering this inclusive work environment and acknowledging that racism is a crisis. It is something that we have to address in healthcare. And in the US, most of our systems like healthcare and education and our justice system were built, unfortunately, on a foundation of white supremacy and racism. And so are we accountable to how it began? No. Are we accountable to how we perpetuate it? Yes. And that's our call to action at our institutions, especially when we're working in pediatric care. So we went on a journey to define, what do we mean by EDI? And how's that different from anti-racism? They are different. EDI can be a very, very positive thing. Equity, diversity, and inclusion. Those all sound great. Sounds like a strategy in and of itself. And in reality, if it is not done in the framework and lens of anti-racism, it will inherently exclude. This is when we started talking and learning more about systems like anti-Black racism, which, if you think about equity, diversity, and inclusion, we think about the rights of our LGBTQ community, and we think about women's rights, and we think about the rights of those with disabilities. If we are not actively approaching those systems with an anti-racist framework, often people of color get left behind. We've seen it in time and time again with these movements. And so it was very, very important for us at Seattle Children's to acknowledge that EDI, equity, diversity, and inclusion, is so important. This is how we drive inclusion. This is how we drive a sense of belonging. This is how we address the ever-changing needs of youth and adolescents and young children across the span of their lifetime. And if we don't look at that with the recognition that it looks different for a person of color, and it looks different for a Black person, and for us, it looks different for American Indian, Alaska Native patients and families, we leave them behind, and we don't actually address their needs, and inadvertently, we continue to perpetuate racism, inequities, and disparities. So this idea of bringing these two systems together and saying it's an active and intentional ongoing engagement. It is intentional, and it has to be something that we're constantly working on and improving. So what we built was an anti-racism organizational change plan. I'm going to reference it as AROC because that is a mouthful and we healthcare workers love acronyms. So we built AROC. This started in 2020. We launched it in October fiscal year 2020. We broke it up into 6 domains. And the idea behind these domains was we looked at our whole system and we categorized them by patient and family experience, policy review, education, and leadership are the 3 I'm going to start with now. For patient and family experience, we sort of combine this idea of outcomes and experience, and how are they different, and how does our workforce reflect our patient population, and in turn, what impact does that have on a patient and family experience? So we thought to improve experiences and increase participation for people of color in research. And one of the things that propelled us here was we recognize even a diagnosis that might be familiar to our emergency department physicians and nurses might look different on a person of color. It might come across different and be explained different by somebody who uses a language other than English. And when we think about even diseases such as cystic fibrosis and sickle cell disease, cystic fibrosis has advanced exponentially in the last 20 years. Outcomes for this patient population have improved tremendously. They have a lot of visibility. The research and donors and funding and attention on this disease is profound, and it is deserved. It is deserved. It is not the same for sickle cell disease. And I think we can all agree that a big difference is we know who's typically impacted by sickle cell disease. And so when you look at our system, even at Seattle Children's, and we take a deeper dive into the resources and attention and intentionality around these 2 diseases and how different the clinics run and how different the experience is and how different the hospitalization is and care and believing when somebody's in pain, we have to go deep. We have to recognize that we perpetuate that even when it's unintentional. And so it's very, very important. You'll see that I started with patient and family experience because what I also don't want to get lost in this plan was that AROC finally established who we are accountable to. We are not accountable to our donors. We are not accountable to our foundation, to our executive leaders, to our frontline staff. We are accountable to our patients and family. And all of that energy and shared mental model around a mission for equity and access for all is how we are accountable to ourselves and to our workforce. But we didn't want to lose sight of who we're providing care to. So you'll see that's why that's first. The big gold orange item was our aspirational goal of eliminating disparities for BIPOC patients and families. We will go into more detail of how we've expanded on that and really refine that statement so that it can be something that's more attainable. Next was around policy review. It's also really important to think through in history, change happens when policies expand and become anti-racist. If I don't have a policy that indicates this is our code of conduct, or a policy that indicates hand hygiene, or whatever it may be, engagement with patients and families, I don't have a foundation to stand on. And where we started was around our workforce policies. We wanted to address concerns about bias and discrimination because what we found was that we tolerated a little too much racism in our workforce. It's a lot harder to argue about bias and microaggressions because when you've experienced a microaggression, you know what that is and you know what that feels like. And if you're communicating with somebody who's never been through that, it's a lot more difficult. And so we needed to try to modify our workforce policies to address those things and to hold departments like human resources accountable for when people of color come forward and have concerns about this behavior, about racism, and that they're believed, and that we have systems in place to move us towards corrective action or rebuilding or engagement, education, and learning. Which leads us into, it's really difficult to enhance policies and introduce new systems without education and leadership. And so towards the end of our conversation today, I'm going to have some takeaways for all of you. And I think it's important to remember in all of these slides, I want you to see where you're accountable as an individual, where you're accountable as an organization, and where you're accountable as a leader. And we believe that leaders lead the way, you pave the way, you model these behaviors, you're responsible. The folks that you are leading believe in and have a shared mental model with your vision. And so we wanted to make sure that every leader at Seattle Children's understood bias, understood racism and oppression and microaggressions, and knew how to engage with their workforce around these matters and normalize it as a topic of conversation. We also wanted to commit to having some sort of health equity, diversity, and inclusion council, which we'll get into more detail about. The other three domains we talked about was around workforce experience. And this has been a big ticket item. We think about inclusion, we think about having that sense of belonging, and what we got from our workforce and groups, specifically, our gender diverse workforce, feeling silenced, feeling like they had to disappear, feeling like they had to leave their identity at the door. And it's really important for us to recognize and evaluate how discrimination and bias and racism shows up in the employee life cycle, from recruit to the hiring process, to compensation, to retention, and why somebody ever chooses to leave our organization. So we spent a lot of time thinking about, how do we report on bias and discrimination? How do we even evaluate workforce experience as it relates to a sense of belonging and inclusion and diversity? And finally, do we reflect the patient population we serve? The true answer is no, we don't. And we are working tirelessly to make that happen, but we needed to go on record and say, we're not there yet. And so let's set that into a goal. Next is around data analysis and transparency. So this is really a message for all of my clinicians and all of the QI folks on this call right now, that it is very important that the Center for Quality and Safety align with, acknowledge, and believe that equity is your problem. It lives in your system. It's tracked through your QI initiatives. It's tracked through your outcomes, your data, your metrics. And so if you're not embedding equity by looking at things by race, ethnicity, and language, even as a place to start, I can't in good conscience say what you're doing is quality and safe care. It cannot be quality and safe care if it is only for white patients who speak English. And so I urge you, similarly to how we've done it at Seattle Children's, we are very closely connected to our Center for Quality and Safety. We have a very specific domain for equity where we evaluate all of our measures. It is required that all hospital metrics are also stratified by race, ethnicity, and language. And it's not enough to just say, yes, I found a disparity. It has to be matched with interventions and progress. And that metric will stay red, and you will come back to our steering committee month after month after month until we see that metric go from red to green. And so I just want to be clear here that it's no one else's job but your own. And we had to take that accountability ourselves and learn that. And it's been rocky. And I think we are trying our best to try on different interventions and QI initiatives, and how do we build a key driver diagram that embeds equity, and what are the tools that we need to make that happen. But that commitment and alignment from the Center for Quality and Safety was huge in our ability to move some of this work forward as it relates to patient outcomes and care. And then lastly, our final domain was communication and community engagement. And so when we think about being accountable to our patients and our families that we serve, ultimately, we have to be adhering to the needs of our community. And a part of that is around transparent communication, honest communication, and engaging the community so that we aren't making it up as we go along. I don't necessarily know what the community needs. And so if we're going to be building strategies or new programs or interventions and initiatives, we have to engage the community in a meaningful way, not as a token and not as a rubber stamp, but truly co-design. We wouldn't be here without our community. And so we owe it to our community to engage them in our hospital operations. So all of that sounds lovely. And then the bumps in the road. We thought we were forging ahead. We thought we were making progress. We thought we were doing so great as an institution. And then the fear starts settling in, and the fragility starts settling in, and white supremacy culture and status quo starts to take hold. When we're in crisis, we often lean on our biases. We often lean on that status quo, the thing that we know will get us the results that we need and want. And so when we start talking about anti-racism, when we start disrupting these systems and this status quo, it's uncomfortable and people feel unsafe. And the fear of, I'm not racist, and somehow if you admit to any of these activities or behaviors, that you are somehow conceding that you are not anti-racist. And I'm here on record to tell you that you can be racist in one moment and anti-racist in the next. It's not who you are. It can change throughout the day. And what matters is your continued commitment to do better, accept what has maybe gone wrong, and just commit to do better moving forward. We had some challenges in the Quality Center around unlearning some norms and in re-examining what we mean by best practices. If best practices were developed and built on a system of white supremacy and racism, it's very hard to use those best practices to be anti-racist and equitable. And so it has taken a lot of trial and sometimes error to get where we are today. And something I always like to leave my clinical folks with is, you know, we are advancing healthcare in a way that I'm sure 50 years ago, nobody could have imagined. 50 years ago, 75 years ago, a surgery to correct hypoplastic left heart syndrome, that was a death sentence. I'm so thankful for the clinicians who came before us and took a chance and took a risk, studied and tried to get to where we are today, to not have that be a death sentence. Equity and anti-racism are the same thing. We are dismantling systems that are very profound and deep in our system and deeply rooted in your system in Canada as well. And so I don't want us to think like this isn't a big scope. It is. And just like healthcare, just like research, we have to try and study and continuously try to improve. We had a prominent leader at our organization, a Black senior leader, physician, Dr. Ben Danielson, very publicly resigned from our organization after 20 plus years of being with us. And he went on record to say he left in part because of racism, being overlooked as a Black male, because of the way he was treated, and a lot of other significant accusations that was in the news. And it was across the news cycle. We had some local celebrities supporting him through Twitter and Instagram and other social media accounts, and it was devastating to our organization. We had a mass exodus of Black and African American employees. We had patients who fired us as their clinicians and moved on from our organization. The community started a petition to have our CEO and Board of Trustees chair step down from their roles. And we are continuing to battle rebuilding trust and restorative justice with our community. Ben Danielson resigned in December of 2020. And we still struggle. And we're trying to be accountable. As a result of this, the Board of Trustees ended up actually hiring and building a committee to respond to the accusations of racism at Seattle Children's. And ultimately what they decided was for Seattle Children's to undergo an investigation by the former Attorney General under the Obama administration, Eric Holder, and Covington and Burling's assessment. It was 7 months. It was a very thorough investigation. Over 1,000 workforce members, patients and families and communities participated in said investigation and offered several hours of dialogue, emails, documentation, hospital metrics. The release of the findings occurred in August of 2021 and also created some controversy. The Board of Trustees determined that they were not going to share the full report with the organization or the community. We saw a summary of the findings and we saw the 88 recommendations that came from this report. And so once again, we had an unfortunate circumstance that led to further broken trust with our community. And I believe that our Board of Trustees and our executive leadership team did their best to act from integrity and to do what's right for our patients and families and our workforce, but the impact was vast. And we're still having to manage that today. So what that meant was our $3 million AROC strategic plan was not going to cut it. So cut to today. We took the time, 30 days, executive leadership team, myself and another senior spent 10 hours a day, at least 6 days throughout for 30 straight days to build our health equity and anti-racism plan. Wanted to make a true commitment. We recognized that AROC was a great foundation. It addressed a lot of those domains and challenges we had across our organization, but $3 million and the limited resource that we applied to it wasn't going to meet those needs. So we had to have a conversation about resources and funding for this type of initiative. We had to think about the Center for Diversity and Health Equity and the programs that they offer around research and clinical care and outcomes. We need to think about an initiative that would be seen as an institutional priority and that it would be funded accordingly. A strategic plan that only lives in your people and culture division is the responsibility of your people and culture division. A strategic plan that spans across an entire enterprise and an entire executive leadership team and is funded accordingly is everyone's responsibility, from the frontline staff up to your CEO. This includes needing to expand opportunities to create more of a sense of belonging through workforce. We call it workforce idea, inclusion, diversity, equity, and access. We had to think about what other resources are needed and what other accountability measures are needed for quality and safety, talked about earlier. We have a program called Gather, which is to generate and teach health equity routinely. This is specific to learning for physicians. Physicians have a different role in the organization, and the more we try to pretend like they don't, the less we engage them. And so how do we create learning opportunities that actually meets the need of our faculty? We had to take a deeper dive into measuring equity through our quality core measures, and we really hyper-focused on CLABSI. I know all of you are invested in CLABSI, just like we are. And we have an entirely separate metric to make sure we have no disparity. We recognize that we had a difference in outcomes as it relates to CLABSIs, non-MBI CLABSIs, across our institution for Black or African American patients and patients who use a language other than English. It's a standalone metric on that dashboard. We have interventions like auditing every central line for all admitted Black and African American patients, 100% of the time. Even if we're not concerned that they might have a CLABSI, whatever it may be, they need central line auditing. We recognized over a 6-month period that our randomized audit system didn't actually include Black or African American patients. We've had to do some deep dive data analysis to get there. And I'm proud to say right now that metric is green. We have an entire team made up of nurses, APPs, MDs, family advisors, and equity specialists who meet once a week. And we drill through that key driver diagram every week. We test our interventions, we see if they're having impact, and we expand on the ones that do. And so it does take time and it does take resource. We've established some enterprise-wide outcome measures and action items as well. And we've established something that's called an equity impact assessment tool. This is available on our .org page, something that any organization, any equity intervention can utilize, you as well. This tool is meant to embed equity from the beginning. Often what happens is we build all these strategies and programs and initiatives, and when it's all said and done, we say, oh, let's see if families think this is a good idea. Let's see if this is equitable. The goal of an EIA, an equity impact assessment, is that you have to do it from the beginning. You have to assess and analyze where disparities and inequities might exist. You have to engage your community, your patients and families as well. This has been a really important tool for us in that quality space, and I'm happy to share it with all of you if you have interest. We did establish our Health Equity, Diversity, and Inclusion Council. We have our HERE action plan, which is our Health Equity and Anti-Racism action plan that feeds into this heady council. It's made up of 6 committees that focus on those 6 domains that I read earlier from our AROC plan. Each committee has embedded patients, families, and community partners in them. They are paid for their time. The staff who sit on this council are paid for their time, and their job is an oversight committee to ensure equity impact assessments, diversity, inclusion, and anti-racism are embedded in every single outcome measure that we have in our institution. The new plan for 2022, we base this off the recommendations from our assessment from Eric Holder. Recommendation 1 was Seattle Children's needs to make and sustain an unequivocal commitment to anti-racism and EDI. Our commitment here and outcome measure is that the Board of Trustees was charged with updating Seattle Children's values to include anti-racism, to hold leaders and workforce accountable through performance evaluations process. Our new mission and vision and value statements have anti-racism and EDI embedded in them, and they are now a part of your performance. You have to perform here if you want merit increases. You have to perform here if you want to be considered a high achieving employee or leader at our institution. And that goes all the way up to our executive leadership team. Recommendation 2 is to lead the institution with purpose and decisive action. We are charged with linking executive compensation to achievement of anti-racism action plan outcomes. That outcome measure is only for our executive leadership team. You are now required, and your compensation is tied to being anti-racist as an executive leader. Recommendation 3, hire to increase and sustain diversity. We want to increase our employee diversity, race and ethnicity to 40% to further reflect our patient population. That's our year 1 goal. The ultimate end vision is that we completely match it, which would be between 48 and 50%. Recommendation 4 is to build and sustain a culture of inclusion in the workplace. We have a workforce survey that goes out annually. We have questions in that workforce survey that are very specific to diversity, inclusion, and anti-racism. We want to improve the inclusion indicator scores. This question is, this organization values workforce members from different backgrounds. That's what we're considering our indicator question, and we want to see change and improvement in that year over year. Recommendation 5, we couldn't decide on one, so we plugged in 2 outcome measures to include patients and families in the journey. We want to, as I said before, eliminate any disparity associated with the non-MBI CLABSIs. We have a system called Code Purple, which is our behavioral response that includes behavior support, psych support, and security. There's a disparity. Code Purples are often called more on our Black families and patients than any other family, and that's consistent over 8 years of data analysis. We decided to abolish this system and rebuild something new through a true co-design process with our community. We're in the process of doing that right now. Recommendation 6 is to listen to workforce patients and families, achieve a significantly improvement on the family experience survey as well. So we also need to think about how we collect these surveys. They're not always translated into all languages, and so it's important for us to make sure that we're reaching all families, regardless of the language you use, and regardless of your race, ethnicity. Recommendation 7, communicate transparently. We redesigned our reporting on anti-racism. We have a quarterly report that is extensive. It's on our .org page. We are doing our best to not have any closed doors and behind the scenes, because whatever we're working on internally impacts our patients and families externally. And so it's important for us to communicate transparently with the community. And last but not least, we have our recommendation around leading the way. I participated in a work group, a national work group, the US News World Report and reporting on the best children's hospitals. And we built a health equity disparities and inclusion survey that was embedded into the US News World Report survey that went out in January. And so we may not have it all figured out at Seattle Children's, but we feel like we have enough under our belt to share that knowledge. And that's what we've done. That survey was released in January. We don't know how it's going to impact folks' rankings. We didn't participate so that it would impact our rankings. We did it because we knew it's the right thing to do. We're also moving forward with systematically collecting social determinants of health data from all patients and families on an annual basis so that we can make decisions about resources and funding. So I think I want to wrap us up here by talking about what does it actually mean to live our values at Seattle Children's. And these are important bullet points, so I will read them to you. Is we want to lead with intention to be an anti-racist organization. We want to identify, challenge, and change systems to ensure we have racial equity. Develop and promote anti-racist policies. Provide fair opportunity and promote that sense of belonging. Develop explicit accountability measures and guidelines and an audit system focused on equity, diversity, and inclusion. And lastly, ensure EDI is not paused or seen as additional work. This is our shared work. It cannot be paused when things get busy. I have a few pieces of advice for you all as well around dismantling the status quo. I know that this work is filled with passion and trauma and challenge, and some people feel threatened. This status quo is what we call white supremacy culture. There's a fear of open conflict in white supremacy culture. And we cannot achieve equity, diversity, and inclusion and anti-racism without healthy conflict. So when someone raises an issue that causes discomfort, often the response is to blame the person, to make them feel like they're the enemy, There's an emphasis on being polite, and alignment and agreement. And that's not how we raise difficult issues. That's not how we have difficult conversations. Respect, absolutely. Brave, courage, absolutely. So the antidote to this, I believe, is that we need to distinguish between being polite and raising hard issues. They're two different things. We need to distinguish the difference between uncomfortable and being unsafe. Because when we learn, for those of you that have done any sort of training, and when you became a nurse, were you nervous your first day on the job? I hope so, and I hope you learned from that. And I'm sure the things that made you nervous on day one don't make you nervous now. Were you unsafe? Probably not. Don't require those who raise hard issues to raise them in an acceptable way, which means you don't get to decide when somebody is feeling harmed by racism. That's somebody else's experience. Only one right way. This is where we continue to work and mold and shift with folks like our Center for Diversity, our Center for Quality and Safety, and that this best practice. There's one way, it's this or that. Equity, diversity, and inclusion and anti-racism challenge us to think about diversity in how we think. Cognitive diversity allows for innovation, creativity, and errors, and being able to pick up and with agility and resiliency to shift and change direction at the drop of a dime. It's okay to not have one right way. There are multiple right ways, and we need to see value of the culture in others and the communities that we serve. So before I read my ending quote here, I want to ask all of you from your takeaways here. As an individual, my ask and charge for all of you is that it is your responsibility to engage in your own learning around equity, diversity, and inclusion and anti-racism. It's your responsibility to unlearn things like white supremacy and patriarchy. It's your responsibility to consider your own biases, explicit and implicit, and to understand that equity and diversity and inclusion is also your responsibility. And when you work in a place that has established that as a value, it's your responsibility to have that shared mental model. And if you don't, then perhaps it's time to find a new place to work. And that's okay. That's okay. A lot of this is heart and mind work, and a lot of this is policy and institutional work, and we have to find balance there. Second, I call to all of the leaders on this call to remember that you lead the way and pave the way for your teams. People look to you to model what is acceptable and what is not acceptable. And you are only as racist as how much racism you will tolerate. And so I implore all of our leaders across Canada, across the US, across health systems to be reminded that it is your job to model this for your teams. And lastly, the institution. You have to make a commitment to EDI. Remember how I talked about our original AROC plan being $3 million, and we thought we had won big because it was the first time that we had any money invested in something like this. When we really sat down and evaluated how much work was going to go into this, it's a $25 million strategic plan for just the next 2 years. We recognize that EDI and anti-racism is a big lift. It's a lot of work, and it's not enough just to have a chief diversity officer anymore. That won't cut it. There has to be funding, appropriate dollars, and appropriate resource that cuts across your clinical work, your research, and your hospital operations. I'd like to share with you that our funding for the HERE Action Plan is solely from hospital operations. It's not dependent on donors. It's not dependent on our foundation or who wants to invest in it. Our board of trustees decided to prioritize it. And so to truly call it a strategy and to truly hit the mark, we have an organization of 13,000 plus individuals. It costs money. It costs money to create that sense of belonging and to translate that into health outcomes for our patients and families. So I encourage your institution to think about that and how are you truly investing in it, not just by your words, but by your actions. So I want to leave us today with one of my favorite quotes, just to remind us that this is our shared work. It's our shared journey. And we all may have differences in what this looks like, depending on where you live and what region of the world you're in. But ultimately, we all have to come in and do this together. So I'll end by saying, I have walked that long road to freedom. I have tried not to falter. I have made missteps along the way, but I have discovered the secret that after climbing a great hill, one only finds that there are many more hills to climb. I have taken a moment here to rest, to steal a view of the glorious vista that surrounds me, to look back on the distance I have come. But I can only rest here for a moment, for with freedom come responsibilities, and I dare not linger, for my long walk is not ended. I'm very thankful to be in the role that I'm in. I am thankful that I did not have to walk the journey that somebody like Nelson Mandela had to walk. And I'm very committed to this work, and I'm very committed to the patients and families, and I'm inspired every day by people like T. And I'm inspired every day by the patients who choose to walk into our organizations to seek care. And I'm very thankful for this opportunity to come share with you, and looking forward to having some dialogue.
Wow. First, I want to pause. There have been quite a few questions that have come in. I want folks to really sit and take that in, those pearls of wisdom. Natalie is going to really pick some pertinent questions, but I want to reassure folks that the recording of Alicia's conversation and all of the questions you have posted will be answered, and we will post that on our line. And so Natalie, over to you. Let us continue the conversation. Amazing. Thank you, Alicia.
I absolutely agree. Amazing conversation and amazing talk, Alicia. Thank you for giving us so much to think about and to reflect upon. In terms of how we can all learn from your experience and your work and initiative at Seattle Children's Hospital. And key takeaways that I think is important to remember, how we can be accountable for how we continue to perpetuate racism and oppressive practices within our institution, both at the individual level, at the organizational level, and leadership level, how we need to be active and intentional in making sure that we tackle EDI and anti-racism work, and also looking at the AROC initiative plan. This tells us that it is feasible and that it's important to look at it through the lens of patient and family experiences, policy reviews, data collection, and how we make sure that we have clear metrics so that we are accountable for the work that we do. But most importantly, this is an ongoing journey, and how we need to make sure that there's a commitment to focusing on this work, which means that it requires time, hard work, and funding as well to push these work forward. So there's lots of questions coming through. I will start with the first one here. So a lot of positive feedback here. So first question, our families have given feedback that collecting real data at the point of care feels unsafe. So many won't answer or put inaccurate information. Wondering how you collect that data to ensure a sense of safety.
Yeah, that's a great question, and one that we struggled with as well. So I appreciate you asking it. I think what's important is that, you know, when our systems are built on, unfortunately, a platform of white supremacy and racism, families feel unsafe. They feel like sharing that information is going to be harmful to their patient or their child. And so it is our job to, one, focus on that restorative work and building trust. We do really good scripting for registration and our MAs and CNAs and folks who check families in when asking that. And so we tell the story of why we collect it. And a part of that scripting includes language like, at Seattle Children's, we really value diversity. We really value the identities of our patients and families. A part of why we collect this information is we want to make sure that we are meeting the needs of the community we serve. We learn a lot when we learn more about you and your family and where you come from and your zip code and the language you use, because we want to make sure we're the best care possible. And so we often tell folks, it's up to you if you want to share that. And we continue to engage the family and build trust. And when they say no, it doesn't mean it's a closed door. It just might mean we have to do a little bit more effort to build that trust. But I think what families want oftentimes is some transparency on why we're doing what we're doing. And so we have had some experts come in and help build that script for families that ask the questions. But it's been a challenge. And so we do have I think we've finally gotten our percentage of families in the unknown refused category down to 2%. What used to be much higher than that. So I believe that scripting and communication and just constant trust building has made a big difference in families' ability to engage with us.
Thank you for that. Yes, the importance of really having that appropriate language and also providing that context to family in a transparent way. Next question. Alicia, I'm thoroughly enjoying your presentation. Thank you. So when you spoke about the bumps in the road and the fear that crept in, can you talk a bit more about how you moved individuals past that, to return the focus to the work at hand?
Yeah, so I think when we are engaging in these types of conversations, that fear of being accused of something starts to creep in, and the fear of making a mistake starts to creep in. And this is why it's so important to lead from a place of growth and engagement and learning, training and policy. All of those things combined creates a system where I think it's okay for people to walk on eggshells a little bit. I know we often shy away from that. The idea of walking on eggshells, in my opinion, just means you're being thoughtful. It means you have spatial awareness of the people around you. It means you're reconsidering the words that are coming out of your mouth and perhaps having a filter, because laughter and love and compassion and kindness can all exist without you making comments about somebody's hair or body or skin color or clothes that they're wearing or behaviors that you don't agree with and align with. And so part of it means that you have to be able to engage head, heart, and mind. And the other piece of it is moving away from language like zero tolerance and engaging safety language like zero incidents. We know that we're not going to eliminate, eradicate, or get rid of disparities 100% tomorrow or racism today. But what we can say is we'd like to focus on zero incidents. And that comes with education and patience and grace without sacrificing the support, kindness, compassion, and protection that people who are often oppressed experience. So one can't weigh more than the other, and you have to have equal resource to ensure that restorative work, a sense of belonging, and grace, education, learning, and opportunities to change happen. So there's a spectrum of racism that we've created at Seattle Children's, and it's not like, oh, you commit a microaggression, you're fired, you're out, you're written up. It's, okay, you committed a microaggression. We're going to have a conversation about what that means. We're going to provide you with some education and coaching. We're going to remember that. So if we get a report from a month from now and then another month from now we're tracking that maybe you're having a hard time adhering to the values at our institution. And that's when we start talking about corrective action. So there needs to be a spectrum and there needs to be a path ahead that everyone has clarity on. So there are no surprises. But I encourage folks to remember, it's okay to be uncomfortable. It's okay to walk on eggshells until you get more comfortable making a mistake. And the goal would be, you said something that I didn't appreciate. I'm going to tell you that, and you're going to acknowledge it. You're going to validate my experience, and we are going to move on together. And that can only happen from a position of trust and willingness to commit to doing better moving forward.
I absolutely love that idea of shifting from zero tolerance to zero incidents. I'm trying to move on to the next question. So many great questions coming through. So thank you for sharing AROC and your learnings along the way. Can you speak to the GATHER program for physicians and how that differs from the EDI education that the rest of the organization leaders receive?
Yeah, absolutely. GATHER is something we're so proud of. It's really rooted in quality improvement. It's through our maintenance of certification program for our faculty. And it takes what, in my opinion, is not worthwhile, maybe a 30-minute or 2-hour online EDI training that teaches you some definitions, which is helpful, but it doesn't actually change behavior. The GATHER program, you are with a cohort. You are constantly evaluating the impact that the reading materials and the sessions that you have with your cohort has on you, your practice. And if you happen to be on a clinician educator track, how does that impact how you train and manage residents and trainees as well. There's a hyper focus on EDI in these spaces. They come together for an hour. It's a facilitated conversation. It's a very vulnerable and honest space. And we like to bring faculty together from different parts of the organization. So in one meeting, you might have a hemonc doctor as well as an emergency room doctor and a general medicine and a hospitalist, and then maybe a faculty from bioethics. They're all coming together to talk about these series of questions that we just ask over and over and over again. And those conversations are so rich. And our ask is to take that back and practice it and then come back to the group. And it's a safe space with trained facilitators, and it's really faculty run, led, and participated in. So each cohort can last anywhere from 6 months to 9 months. We've had faculty who have come back to do it again more than once, because you can join a different cohort and learn something new. And so our goal for the next 2 years is to ensure that every faculty member goes through it at least one time. And so the hospital has also resourced that accordingly with the appropriate administrative and program management support that it needs. And ideally, we'd love to move beyond just our faculty at Seattle Children's and University of Washington and open it up to our community care providers as well. But it's a wonderful and incredible system that is very much appreciated by our physicians, and we're very proud of it.
That's fantastic. Thank you so much. I am very mindful of the time. Do we have time for one more question?
Yeah, let's say. I see the numbers are joining instead of decreasing, so let's fit in one more if we can.
Okay. So last question. I wonder if your data about the Code Purple can be shared. We have not collected race-based data in Canada, and I have been concerned that it would play out exactly as you described. I'd love to learn more about this from an EDI colleague at McMaster's Children's Hospital. As an aside, they're mesmerized by your talk as well. So yes.
Yeah, I did offer this to T as well, that if there are side conversations that need to get more in depth in some of the high level topics I discussed today, like CLABSI, our quality work, the Code Purple, we look at our Code Purple behavioral response as well as our restraints, because we do have an inpatient psychiatric behavioral medicine unit. And looking at how we stratify that data, I'm more than happy to have those in-depth conversations. A little bit more complicated to do that in a large setting, so I'm very, very open to sharing the systems that we've used to collect this data, our analysis, as well as what we're doing to make those changes. So yes, it's not a secret. Happy to share if folks are interested.
That's amazing. Thank you for that, Alicia. And I do want to flag that Alicia is supporting us in working with Connie from Quality and Safety and Andrea in regards to how we can use our CLABSI dashboard to really implement some of this work from a clinical space. On behalf of the Equity, Diversity, and Inclusive Office, I would like to thank you all for joining in this conversation. The questions keep rolling in. I'm going to keep it open for a little bit. Thank you, Alicia, personally, professionally, for your support and ongoing guidance in this conversation on how we can mirror and learn from what Seattle has done in the growing pains that you may have gone through, and hopefully preventing some of our own cuts and bruises, but how these lessons are necessary in the journey. And so I want to thank you, and I want to thank the 200+ people for joining the conversations. I want to thank LICSW for leading such a profound, cutting edge, innovative, keep talking about speaker series here at Sick Kids for Black Health and Liberation Month. I want to thank Marta for holding us all together, and Ashna for joining our team and hitting the ground running, and every one of you for leaning into these conversations and recognizing that it is all of our responsibility and honor to do this work, to truly be the #1 health institution. And on that, I wish you all a great day, and thank you so much, and love upon yourselves and be good to each other. And that's it.